Thank you. And these are my disclosures. Just real quick summary of what Manny did earlier. And when we're talking about pulmonary embolism, it's very important to divide it into three categories. The minor, which you see in the far right screen, which shows the standard pulmonary embolism, which is the most common, about 55% of most pulmonary embolism, which is treated with basic anticoagulation. And then you can divide into the submassive and massive. And right now we're going to focus on mechanical interventions mainly for massive and submassive approach for these patients with pulmonary embolism. And so if we look over overall view of treatment for pulmonary embolism, there's obviously anticoagulation, but it has its drawbacks because it relies on endogenous TPA to resolve the majority of the clot. Systemic thrombolysis, we use standard for a massive PE that have hemodynamic collapse, but they typically has a higher bleeding rate than average. And then the catheter-directed thrombolysis still lacks the support, but it's not been quite proven to be superior to systemic thrombolysis. And of course, mechanical, which I'm going to talk about, has really no level of data that's very supportive. And then surgical embolectomy, which I believe Dr. Stewart will talk about later in this session. So the indication for mechanical thrombectomy is really not that strong of support, but we know when there's hemodynamic instability in these patients with massive PE, we tend to use mechanical thrombectomy. If the patient starts to deteriorate after thrombolysis and continue to deteriorate, these patients are possibly using mechanical thrombectomy. And of course, patients with acute pulmonary embolism that can't take anticoagulation, and later in the session I'll present a case with that, and cannot take systemic thrombolysis for a variety of reasons. The submassive patients that have hemodynamic instability have like a total occlusion of the main trunk that are worsening, then we tend to use mechanical thrombectomy. But it's important to note that a lot of this has not been validated. They lack large randomized trials, and they're pretty much driven by operator experience, and there's not really a good, clear guidelines of what needs to be done for mechanical. So one of the devices that we want to discuss briefly is AngioVac, and this is a device that's used for clot aspiration. And as you can see at the bottom of the screen, it's a very large sheath, and you can see it as a catheter is advanced into the pulmonary trunk selectively in the right pulmonary artery, which uses suction into the device and out through the return catheter, and it's filtered, as you can see the color picture. But this is a pretty extensive device, meaning that you need a perfusionist. There's a lot involved, and the setup time takes quite some time. Coming around the corner from the main trunk is always a challenge because the device is very bulky. But this is just a picture of it and some of the clot that we took out in one of the cases. There's other devices that are newer on the market, a Flotriever, which uses a catheter that has like a trap. It traps the clot, and it's sucked into the catheter itself, and then the catheter has a suction capability where we can do it, and then the whole apparatus actually is withdrawn, and you can place it back in for retrieval. AngioJet uses, obviously, we've used this in the coronary and peripherals as well as for uses Venturi-Bernoulli effect, and now that comes in 8 French, which kind of helps, but you also have the capabilities of adding thrombolytics in the solution. Penumbra is another device that's been used. It's mainly used for patients with stroke, but now we use it in the peripheral and pulmonary embolism for smaller branches. You can use a suction and aspiration of the catheter, but it has a stylet that kind of breaks up the clot, and it goes in and out and does a pretty good job. The drawback of it is just very small, despite being the 8 French size. For the pulmonary trunk and pulmonary arteries are very large diameters, and it has some significant limitations. There's other devices, AngioJet, that uses like a whip pattern where it kind of uses a whip to break up the clot, and you could also inject some TPA in there as well. There's ultrasound assisted devices that we can use as well, and that's what we call ECOS catheter. We use ultrasound as well as a catheter infusion. And there's 3 smaller randomized trials, the Ultima, the Seattle, most recently Optilis, all showing that there's a decrease in the RV-LV ratio, as well as a decrease in clot burden, which is probably more commonly used for the submassive and massive PE. These are just examples of before and after using a variety of these mechanical stuff. And so the key that I wanted to bring this up with this image is that we're not expecting complete resolution as we do with coronaries. We're not expecting stenosis decrease to 0%, or in the peripherals where we accept it at 30 to 40%. There can be clot burden. On the right with the post image is not typically what you would see post-procedure. You're not going to see a complete resolution. This is done weeks out later. So in conclusion, the massive and submassive PE are still underdiagnosed and for the most part undertreated. There's a high mortality in these patients. And once again, I'm excluding the minor, commonly seen pulmonary embolism. And it's still the guidelines and the validation of some of these mechanical equipment is still not been validated. And the treatment option should be really tailored to each patient because each patient, based on the clinical findings, the hemodynamic assessment during that time period is going to determine what needs to be done next. And I think that every program in a major institute should have a PERT program, which is going to be an innovative solution to a largely undertreated diagnosis. Thank you.